And I will hand things off to our next presenter, Rina. Thank you.
Thanks so much for having me. My name is Rina. I'm a PhD candidate at McGill. My supervisor is Cindy Yang. My research interests mainly lie in healthcare utilization among immigrant mothers in Canada, and I'll be presenting just very briefly on some of my ongoing work. So immigration is the main driver of population growth in the country, and it is projected that within 15 years, up to a third of the Canadian population will be an immigrant. Consequently, immigrant women and their children make up a significant and growing proportion of the Canadian population. Now, immigrants are not a homogeneous group, and one of the many ways that they differ is according to their admission category. Since 1980, immigrants granted permanent residency in Canada have been classified into four major admission categories. Most are admitted as economic migrants for their ability to contribute to the Canadian economy. Almost 30% of landed immigrants are sponsored by a family member or a spouse who is a Canadian citizen or permanent resident, and 15% are admitted as refugees under humanitarian grounds. A small proportion of immigrants fall into the other category, which consists of non-refugee, humanitarian, and compassionate cases. Heterogeneity within immigrant populations has important implications for their health outcomes, and disaggregating the immigrant population helps us identify health disparities that exist within immigrant groups. So inequalities in health outcomes between immigrant subgroups have been identified in the literature. However, most studies still continue to treat immigrants as a singular group. Furthermore, immigrants are also often regarded as healthier than native-born populations, but this advantage, also known as the healthy immigrant effect, is not universal and diminishes over time. It is also well understood that all immigrants face systemic barriers in accessing adequate care, and that overall they utilize primary care less than native-born populations. In Canada, factors that are associated with inadequate healthcare, including limited health literacy, financial barriers, low education, and poor social support networks, differ by admission category. However, few studies have actually examined differences in primary care utilization across immigrant subgroups according to their admission category. So we know that immigrants utilize primary care less, but how can we operationalize their healthcare utilization? Limited access and utilization may in fact lead to delays in diagnosis and treatment of certain health conditions. Consequently, immigrants may experience more hospital admissions for ambulatory care sensitive conditions, or ACSCs. So ACSCs are a group of acute, chronic, and vaccine preventable conditions that can be managed with adequate primary care and include things like asthma, diabetes, hypertension, and angina. Hospitalizations due to these conditions are avoidable, and they're often used as indicators to assess healthcare systems. In Canada, there is a limited body of research that focuses on ACSC hospitalizations among immigrants, and all have treated the immigrant population as a single group. Furthermore, these studies have been very inconsistent in their findings. So one of the main aims of my thesis is to estimate the risk of ACSC hospitalization among mothers by their nativity status and also immigration admission category, and assess how effect measure modification of this risk among immigrants by family income and maternal duration of residence in Canada. And to answer that, I will utilize a retrospective cohort of mother-newborn pairs for approximately 6 million births that occurred in Canada from 1993 to 2017. This study leverages 5 linked administrative databases that are all available through the RDC. This linkage is referred to as the mother-centric linkage, and it includes vital statistics of stillbirths, live births, and deaths, linked to the longitudinal immigration database, or the IMDb, of immigrant landing files and T1 family files, further linked to CIHI's discharge abstract database, which includes hospitalizations for all provinces and territories except the province of Quebec. So I am in the very early stages of my work and still mostly doing data cleaning, so I don't have any results to present today, but I'm grateful to the RDC for providing, pan-Canadian data to, for this research, and I am happy to answer any questions if there are.